Hi, everyone. Welcome to today's webinar, Creating Effective Organizational Harm Reduction Policies and Culture in the Context of COVID-19. I'm going to be your moderator, Lindsay McRae, and I'm with the Canadian Observatory on Homelessness. And harm reduction expert Bernie Pauly has graciously agreed to join us again today to bring you our second harm reduction webinar during COVID-19. For those of you who don't know Bernie Pauly, she's a community-based researcher and educator, a professor in nursing at the University of Victoria, and a scientist at the Canadian Institute for Substance Use Research. She's also been involved in designing and evaluating harm reduction policies and interventions for over 10 years. So she'll be sharing her insights with you here today. We'll be doing a Q&A at the end of the webinar, so audience, please type us your questions in the questions box. And this webinar will be recorded and posted to the Homeless Hub YouTube channel, and everyone who's registered for the webinar today will get a link to that via email once the recording is ready. Also, for anyone who joined us in our last webinar, Bernie has reviewed and responded to all of your questions, and we'll be publishing a blog post with the answers sometime soon. So I'm going to pass it over to Bernie to get us started.
Thanks, Lindsay. I'm here again and really happy to be able to spend some time with people who are working across Canada in housing and shelters, and really interested in how do we make harm reduction culture and policies more effective. It's something that I've been thinking about for many years, and I'm really hoping that after I share some of my thoughts, you'll put some of your thoughts on what you think of the framework that we've done and what kinds of questions and challenges or positives that you see to help us move forward in this important work. I'm located on the traditional territories of the Coast Salish people, which is the Esquimalt, Songhees, and Wasanic nations, on whose traditional territory the University of Victoria stands. And I just want to acknowledge that I'm a visitor here, and for the privilege of being able to live and to work here. I have been very fortunate to work with many community partners who have really helped to inform this work. Solid Outreach in Victoria, one of the peer-run drug user organization, AIDS Vancouver Island, which is now just which is called, I'm just trying to think, they changed their name, but I think it's still AIDS Vancouver Island, Victoria Kool-Aid Society, and then as well a number of funders who have supported much of this work financially. I'd also like to dedicate this presentation to all of those who we love and to all of those that we have lost to the harms of substance use, and particularly during the overdose crisis. In October of actually 2013, I was very privileged to work with many of the community organizations in Victoria and alongside Solid and Canadian Association of People Who Use Drugs, who all brought 14 drug user organizations together in Victoria. And that's the photo that you see there. That was a national gathering. And among those is someone that I would like to especially honor, and that's Dave Murray, who we lost a great leader last week. I want to start with a quick review of some of the things I mentioned in the last webinar, as I'm aware that not everyone was necessarily on that, to just kind of bring into the foreground, why is this focus on harm reduction so important during COVID? One of the reasons is that people who use alcohol and other drugs are at increased risk for more serious COVID-19 symptoms and complications. So, for example, with high levels of alcohol use, there's a higher risk of pneumonia and tend to have weakened immune systems. If people are using substances via smoking, obviously that includes licit as well as illicit drugs. Smoking can increase susceptibility or make breathing problems worse, and opioid withdrawal may also worsen breathing as well. And so you can see the interaction between substances and respiratory problems. There's additional harms that have been created by COVID. And here you see quite a long list of some of the harms related to illicit drug use that's really propelling harms, particularly harms of overdose. And I'm not sure, I'm located in British Columbia, and I'm not sure how many people are aware, but we had 113 deaths last month from overdose, which is more than the deaths we've had from COVID. And, you know, it's been said by some that, you know, the reality of overdose is actually higher for us here in British Columbia than COVID, although I know that's quite different across the country. They are still dual risks, and we are really in dual public health emergencies. So some of the things happening that are propelling that risk are, you know, drugs becoming scarcer, more expensive, more toxic. People have suffered losses of income, closures and changes in locations and hours of supervised consumption sites and overdose prevention sites, limited access sometimes to harm reduction supplies and drug checking because of COVID restrictions. People still need to source drugs daily, so having to go out. And so, of course, in that context, there's the increased risk of overdose, but can also be increased risk of withdrawal, increased risk of using alone, increased risk of bloodborne diseases, and increased risk of social isolation. So the harms of substance use have always been there, but they are escalated by COVID. There's a similar but slightly different picture with alcohol. For some individuals, they have lost their income related to panning and recycling, so it makes it difficult to buy beverage alcohol. It may be difficult to access liquor stores. Liquor stores may not take cash, which is often what some individuals may have. There's been restrictions on the availability of detox and treatment. Again, the need to source alcohol daily, the cycle of survival drinking, and increased with risk of withdrawal, which in some cases with severe or complicated withdrawal can result in life-threatening seizures. Non-beverage alcohol use may be increased. Individuals may substitute illicit drugs in this context, and of course, ongoing increased social isolation. So harm reduction has always focused on preventing the harms of substance use. But during COVID, it can also increase the ability to physically distance, shelter in place, or stay at home and assist with self-isolation. So it still is a prevention, and it's a particularly important prevention given that we're in dual public health emergencies. And just to kind of refresh what is harm reduction, or maybe more accurately, what do I mean by harm reduction? I ascribe to the Harm Reduction International definition, which is readily available in a little document called What is Harm Reduction at their website. And it refers to policies, programs, and practices that aim to minimize negative health, social, legal impacts associated with drug use, drug policies, and drug laws. And they have revised that definition many times over the years that I've been working in harm reduction. And what they have done in this most recent definition is they've really emphasized, whoops, there you go, you get maybe human rights and an emphasis on drug policies and drug laws as a source of harm and the need to address that. So what I'm going to talk about in relation to harm reduction policies and culture is to really try to answer these two questions and then engage in some conversation. First, what makes it so hard to implement harm reduction in housing and shelters? Like, why is this so challenging? And how can effective harm reduction organizational policies and culture help? Part of it is we have to start with understanding our history. This will help us to understand why this can be so difficult. Prior to 1908, opioids like laudanum, here you see in the poster, were actually pretty widely available. They were used for ailments such as pain, to help with sleep, relaxation. They were in a number of pharmaceutical preparations. And so there was not, in fact, they were widely used by middle-class society prior to 1908. So what happened? In 1908, the 1908 Opium Act was introduced, in which substances, particularly opioids, became controlled drugs, and we went into an era of drug prohibition that has continued to this day in terms of our Controlled Drugs and Substances Act. And that's pretty significant because it sets up for all of us in Canada a context in which we work every day, where we are working within drug prohibition. And that is problematic in that it has generated a lot of negative attitudes. It's created a lot of stigma. And, you know, there's been international focus on not just Canadian drug policies, but drug policies around the world, with the conclusion that such drug policies that exclusively emphasize prohibition are contributing to harm of individuals and communities. So we're working in a context in which there is prohibition and damage has been done by prohibition, and also created a set of attitudes around criminalization and stigma that make doing harm reduction work more challenging. And just to note, this statement around drug policy and the calling for an end to prohibition comes from the Global Commission on Drugs back in 2011. So how does drug policy show up every day? It shows up in stigma. It shows up in things like blame and judgment, seeing people to be at fault for drug use. It shows up in criminalization. It shows up in problematization, or what we would call pathologizing people for using substances, and it contributes to limiting listening to voices of people who use drugs. It contributes to fear and isolation. And so stigma is a product of our drug policy, and I think we need to really be aware of not only the policies that drive that, but as I said, oh, I hope this isn't going to result in me close. Sorry, I am not sure why that's happening. My apologies. And it really shows up every day in our work, and we have to, and part of highlighting this is just to make us aware of it. This also comes from the Harm Reduction Coalition in the US. They've created some stigma tools for change curriculum. And I think this highlights nicely kind of what happens with stigma, how it gets into stereotypes, how it gets into labels. So really they're highlighting it gets into our language. It gets into what we expect and roles. It limits opportunities. It gets internalized and reinforced. And, you know, I've heard individuals say, you know, you hear over and over and over again, you know, that you're, you know, labeled or stereotyped as someone who used drugs, and it goes into your brain, and pretty soon you believe it yourself and begin to think that you're worthless. That's the internalization that happens when we have this external process of drug-related stigma. And just to highlight, this gets reinforced every day in our policies at municipal, probably at provincial, regional, municipal levels, in, you know, things like red zone policies, for example, where people are prohibited from being in areas. It's policing, urine drug testing. All of those kinds of policies really are reinforcement and enactment of criminalization. And I know we don't always link them, but they are linked. So I often like to look to Yoda for wisdom. I love the calmness. I love the energy. And he wisely said, "You must unlearn what you have learned." We have been taught that drug policy, that drugs and drug use is wrong. We've been taught that people who use drugs somehow are doing something wrong. And so we have to unlearn a lot of what we've been taught through this process of prohibition for years in order to be able to effectively implement harm reduction in our organizations. I don't think Yoda said this, but I would, because he's such a source of calm and peace. But what Yoda didn't say is, because we're working in this kind of context, we have to constantly interrupt and disrupt. So in order to help in a scientific way, I guess, with interruption and disruption, we created a 7-step harm reduction implementation framework. We haven't officially released this. We were just kind of getting ready to do it pre-COVID, and then decided it wasn't the right timing. And you'll notice it has 7 steps, not 12. But the steps each have a number of kind of sub points and questions in them. So what I'm going to do is go through the 7 parts of the framework. It's a way of generating a harm reduction policy and culture, both, to be able to do the work that we need to do effectively. So I'm not specifically going to talk too much about harm reduction interventions, but I am talking about harm reduction interventions that prevent the harms of a broad range of substances as well. So our goal in producing this framework, it was based on a literature review that we conducted, is to assist leaders, service providers, and policymakers to fully implement harm reduction in program services and organizations, and to promote an organizational culture that supports harm reduction philosophy, policies, practice, so that the scale up of harm reduction interventions is actually easier. And then we worked collaboratively with our community partners to do the lit review, and then the final framework was reviewed by members of SOLID. I think we need to start with the understanding in our work of implementation that through the process of drug policy prohibition, trust has been broken, and we have a systemic gap in trust. And so we're starting often from a place of distrust. And I know that many people work very, very hard every day to rebuild that trust through relationships. And that's a critical part of harm reduction work that can be supported better when we have a harm reduction culture and a set of effective harm reduction policies. And just before I talk more specifically about kind of the culture and policies, where we really need to start is recognizing this broader structural kind of issue related to policies and how harm is being produced through criminalization, prohibition, and how it's been produced by poverty, colonization, and how that's produced kind of harms. And so, if we're really thinking and if we're really serious about implementing harm reduction, everyone in the organization needs to understand some of that history and how it has positioned people unfairly and how it has produced stigma to which we're all subject to. We're subject to it everywhere we go in society. I experience it in my own family. I can experience it among my friends when I hear people talking about drug use. Some of the myths and stereotypes. And we need to recognize that the way people act is influenced by that history. The way that we act, the way that the people we work with act is all being influenced by that. And so, at an organizational level, there needs to be clear messaging around harm reduction as an essential health services to mitigate harm. So that has to be embedded kind of into the organizational being of a housing or shelter, and that there also has to be education, which I'll talk a bit more later, to support that. And it has to be built on a rights-based public health framework. And when we say a rights-based public health framework, we are talking about international rights to health, life, accessing health services, and importantly, the right to participate in services and programs that affect you as well. And so long in the field, we have had the principle of nothing about us without us. That was initially introduced in 2005. That says we must engage meaningfully individuals in the design, development, delivery, and evaluation of harm reduction services. And you see on the right a guide that was developed by the Canadian AIDS Society called Purology, that was done by and for people who use drugs. Second step, I guess, of the implementation framework is ensuring meaningful inclusion of experiential voices in policies, programs, and services. And the reason we put this second and not first was, and we did a lot of discussing and thinking about this, is that the organization has to be ready to do meaningful inclusion. And so that work that I talked about under number 1 really sets it up for this meaningful inclusion of experiential voices, for engagement in developing, designing services. And so, you can see here there's a number of bullet points, and I just want to point to 3 and 4 for a minute. Is there meaningful exclusion of people at all levels of planning and decision making, as well as frontline service? So where are people actively meaningful included, not just sitting as a token, but and then I think number 3 also speaks to the fact that they're supported to develop networks and organize, and then also opportunities for employment, which is number 4, and I would say written policies both around inclusion as well as around things like equitable wages and appropriate supports, which I'll come back to in a bit later. I also want to acknowledge that what I'm doing is laying out the full scope of organizational, full 7 steps of effective organizational culture and policies. And some you may already have in place. Some you may not be able to do at this time, but you may be able to do others. So I would emphasize, I'm giving you the comprehensive kind of checklist, which is what we call it, but it would require developing your own specific kind of set of steps based on where you're at. So you can think about this kind of like an assessment framework. Where are we at? And then identifying what is it we could do. I just want to highlight a couple things about policies related to specifically employing peer workers, and this applies actually to all employees and staff. As a registered nurse, I'm expected to show up ready for work. Doesn't matter what I do before or after work, and the same thing applies here. And the Open Society, I think this document might be close to a decade old, was a guide for organizations employing people who use drugs. Still lays out, I think, very carefully some clear parameters around what is acceptable and unacceptable in terms of employing people with lived experience in organizations. There's also a broad range of documents available from PEEP, Peer Engagement and Empowerment Project, available on the BC-CDC website, documents on how to engage people at all levels in an organization, from sitting on planning committees or developing committees to payment. And they have a nice little poster that can be put up anywhere about how to involve people who use drugs and how to do it in a good way. And that poster is downloadable on the BC-CDC website. It specifically, I think, highlights what can work and what doesn't work in terms of meetings, and particularly how to, some do's and don'ts in that regard. If we're talking about peer, and I apologize, I've kind of gone back and forth from people participating in kind of program and policy back to peer work, because I think those are two different but really important aspects of implementing harm reduction. Our peer-to-peer project, which is led by BC-CDC and ourselves at UVic-CSER, we developed what's called the ROSE initiative, which starts with recognition of peer work, and a lot of the resources for this are on the Toward the Heart peer engagement site. And I would say, if you have peers working or you're thinking about that, I would highly recommend the video just produced called A Day in the Life. It's just out about a week or so, and it shows the work of peers during the overdose response and follows a number of peers. It's pretty short, about 10 minutes, and I'm happy to post a link specifically to it, but it is on the website. So there's a number of ways to kind of recognize. Some organizations that I work have shown the video to talk about what peers do and to recognize and value what they do and how it complements and how it's different than what other workers and employees in the organization might do. Valuing that work is critically important, and also providing, and you can go look at the left, you see organizational support. That's the O in the ROSE. Is the really important kinds of things that peers have identified that are helpful to do their work, like having a job title, having a clear description. When we did focus groups, they often told us they were asked to do everything and anything. Having a contract, being paid fairly and equitably in comparison to other harm reduction workers, getting an orientation, having an ID card. So one part of our project was making sure that people had ID cards. Being part of team huddles. We were provided with examples where people were left out of team huddles in the workplace. Having peer debriefing and support, specifically from another peer, having team building, and of course, we have come to call assistance with living conditions peer navigation. And so that's many of the things that organizations need to do to be effective in implementing harm reduction, and particularly peer workers. The S in ROSE stands for skill building, and you can just see there on the right and left of the skill building, it's not a cube, it's a dimensional figure, octagon, a number of different kinds of skill building that the groups that we work with recommended. And then the E in the ROSE is that it's for everyone. So recognition, organizational support, skill building for everyone. And there's a lot more about that on the website. The third step in third component of the harm reduction implementation checklist is around the issue of harm reduction culture and promoting a culture of harm reduction in which people feel safe to talk about substance use and harm reduction. It's not closed down. Are there educational opportunities? This is really important for everyone to enhance knowledge and understanding of harm reduction. I think a wonderful example that I've heard, particularly from the Dr. Peter Center, which is completely has a very robust set of policies and practices around harm reduction, have identified things like making sure that, the staff who prepare the meals or the staff who do the cleaning have as much and understand harm reduction and have an opportunity to clarify their values and how it fits, as do people who are, shelter workers or frontline workers. And then opportunities for ongoing staff education and training. And you may be well into that already, but so you can check that off on your list. It's just a checklist. The culture piece, and I just want to emphasize why culture is so important. We can have programs and practices on one hand, like, we can set up safer spaces for use. We can ensure no lock zone is available. We can have harm reduction supplies. We might have a managed alcohol program, or we would like to. But we really need a culture, and the culture what puts into practice what we say our philosophy is and what we say our policies. So if you think of philosophy and policies as the things we believe, value, and say, and you think of the programs and practices as the things we do, the culture is what is really the glue, the broad sort of organizational way of being that holds all this together. So I'm just going to highlight a couple things to really help think about how do we mark off the checklist, reculture. And one of the things is our language. What language and phrases do you or others use to talk about drug use and people who use drugs? Here's a little poster, again, from BC CDC. I apologize, I'm using all my BC examples, and welcome very much you sharing examples from where you are. And you can see here language, examples of language using people first language, and what to use and what not to use. And then I think becomes a bigger question of how do we challenge stigmatizing language when it appears? People don't always mean things that they say, but they haven't just maybe thought about it. Can we create a culture where it's okay to say, and this is the interrupting, it's okay to say, I just heard you talk about abuse or a drug abuser. That's not really how I talk about it. I tend to like people first language. And so finding ways to make it safe to do that and to even make it the norm in the culture. I always say that our harm reduction superpower is respect, but it's not give respect, get respect. It's give respect, earn respect, because as I highlighted earlier, trust is often broken, and the place we start is with respect. And how do we create an organization that has a culture of respect? And the way we do it is through our language, the way we greet people. That's really deeply embedding values of harm reduction into our organizations. And I know this is very, very, very hard work. And I realize that sometimes what's coming at us might be disrespect, but I always hear that as systemic. It's about the system. It's not about me. So how do we support harm reduction culture through organizational policy? Here's just a little, I'll give you the full checklist in a minute, but here's kind of 3 quick things that you can do. And the first one is, does your mission, vision, values align with international harm reduction principles? So I literally have done this with many organizations where I've taken the principles outlined in that Harm Reduction International statement, and I've said, are these in your mission, vision, values? And it's fascinating, things like compassion, dignity, respect, commitment to evidence. All of those things are usually somewhere in our mission and vision values, which are really our philosophy. So we already have some things that we say we believe, and it's just extending them further. Then do you have a harm reduction policy? Does it actually exist? I know lots of organizations that say, yeah, we commit to harm reduction, but you cannot find the policy anywhere. There should be a written policy. Do you have a substance use policy? What does it say? If it says zero tolerance for substances, then we have a problem. We're giving mixed messages. The substance use policy, if it exists, need to be aligned with the harm reduction policy. And which, as I talked about in the last seminar, raises questions about the kinds of interventions we need to have on site. And then reflecting back earlier, do you have a meaningful, some kind of policy that speaks to social inclusion or meaningful involvement in real ways that's been developed with and by and for people who use drugs? So here's the full kind of checklist around the actual kinds of policies, from a clear written philosophical commitment. Whoops, I want to go back. From a clear written philosophical commitment to a formal written harm reduction policy. And are those philosophies and policies, does everybody know them? Have they been shared with staff? Are people aware that they even exist? And then are the substance use policies aligned, as I already mentioned? And are they grounded in a human rights framework where we say we respect rights to health, life, access to services? I'm not going to touch too much. I'm just going to briefly touch on the last three parts of the harm reduction implementation checklist. Obviously, then within this broader organizational culture and set of policies, there needs to be adequate funding in order to scale up the actual harm reduction interventions themselves and for a type for a range of substances. And in the last seminar, I touched on, the broad range of services, from supervised consumption sites to distribution of clean supplies, to smoking and inhalation tents, to also things like managed alcohol, which are all examples of harm reduction interventions. Number 6, the sixth part of the checklist is we should not only be doing this during a crisis. And to be honest, we wrote this during the public health emergency related to overdoses because that escalated the importance of harm reduction. In spite of the evidence and the harms, obviously we need harm reduction, not just when we're in a public health emergency. That it means we need it even more. And I think we can say, during COVID, it's escalated the need for harm reduction. But again, not only as an emergency response, how will we take the shifts and changes that we've learned during the various public health emergencies, most recently COVID, and put that into place going forward? And then 7, and this is extremely, I think, important and would warrant a whole set of discussion, webinar on its own, is how do we tailor geographically and also in relation to what might be best for a broad range of people. For example, women, youth, Indigenous harm reduction. These are really, really, really important discussions that need to happen and are happening, and to bring forward what is culturally appropriate and safe to meet the broad range of people who are maybe affected by the harms of substance use. So before we go into our discussion, I just kind of want to end with a couple of reflections. The harm reduction implementation framework that I just shared with you, the 7 steps that we went through, are really created at a time when we still have drug policy that focuses on prohibition. We know that that is not evidence-based. We know that that is harmful. And I just want to highlight ways in which we are also working in a constantly shifting drug policy context in Canada. And I just want to highlight a few things for you that through policy are making changes and are beginning. But remember, we're not there yet. We still have, we have not yet, we are still in a policy that emphasized prohibition, but these are important changes. In 2016, after a decade of harm reduction not being part of drug policy, it was restored as a pillar under the newly elected newly elected Liberal government at the time, and drug policy moved back under health and away from justice. So those were not progressive moves. They were just undoing harms that had been done previously. I have not highlighted every change here. In 2017, the Good Samaritan Drug Overdose Act was put into policy in order to make it safe for people to call 911 without fear of being reported. And then in 2018, we've seen things, since 2018, sorry, we've seen things like the Health Canada applications to be able to establish urgent public health needs site. Those applications through Health Canada exemptions for what would be similar to what we call an overdose prevention site. And then in this year with COVID, exemptions for pharmacists and prescribers under Section 56 to be able to, renew prescriptions over the phone. And there's a whole set of exemptions that make it easier for people to get access to things like OAT. Obviously things, there's many things I didn't mention, like making naloxone available without a prescription, with broadening the range of oat that's available, and most recently in BC, and soon I think to be nationally, the availability of a safer supply. So I think we have to remember that those drug policy shifts are a start. We still work in an era of prohibition where criminalization adds to stigma, drug-related harms, and it makes our work harder. And that's why we need to have such strong and clear, effective organizational culture and policies. If we're thinking about the go forward on this, it's decriminalization and move to even more provision of a safer supply as an alternative to the drug market. I'm always reminded by so many of my colleagues that I work with, and I want to leave you kind of with this message, is that as much as we can use a lot of words around what harm reduction is, on a day-to-day basis, many of my colleagues remind me, harm reduction is love. So my questions for you, we have almost just over 15 minutes. I'd love to know what you think of the framework, whether you think it's useful. If it's not, I'd love to hear that too. We haven't released it yet, so if you think it's better stuck in a drawer, we're good with that. Or if you think there's ways that we can fix it. We've been thinking about the framework as something that might be useful, not just for organizational policies, but also to advocate for, broader policies and as well as funding for programs and services. I just want to say thanks to everybody for showing up when you're so busy, and I know how much people who work in this field are adapting and responding. And so having your expertise here is, as I always say, like gold. Thank you. And I'm so ready for your questions.
Okay, so right now, I guess people are kind of thinking about questions. There's a few comments. So there was Noura B had said, I think especially it's important to have an actual physical checklist for agencies to run through. I also really value the importance of separating harm reduction policies and substance use policies and ensuring that they mirror each other. So that's a comment for you, Bernie. And the first question comes from Jana T. Do you have any specific recommendations or think it is possible to integrate this framework within an agency that embraces 12-step models of recovery?
That's a really great question. Thank you so much for that, because my short answer is harm reduction does not preclude abstinence. In fact, a lot of research that I've done and been involved in, people often will make different choices around their substance use when they've had a chance to kind of, stabilize in a managed alcohol program. We know that supervised consumption sites often lead to people choosing to reduce or to go to treatment. I think, though, the relationship has to be right. If the overarching framework or philosophy of an organization is rooted in abstinence, it's very difficult for harm reduction to take hold. If an organization, though, embraces harm reduction as the overarching framework and policy, then within that, it respects that people make choice around their drug use. And those choices may change over time. And I think where it gets specifically important then to reflect on in the practice is the organization you work in as a harm reduction organization and a harm reduction set of services, is that the place where everyone who has a past or current history of substance use is going to be served? Obviously not. And I'll try to kind of bring this home with an example, is that, in the managed alcohol programs that I work with, sometimes, people, they get stabilized in the program, and then they may make a choice that they want to reduce, which means they're not going to lose their housing, they can still taper. And there may come a point where actually they may move out of the managed alcohol program because they're moving to self-management or they're moving to treatment. So think of the harm reduction organization, and we wrote a paper about this a couple of years, well, more than a couple of years ago. We wrote a paper around how, if you're thinking at a community level, you need a range of services that are going to meet people where they're at in terms of their drug use. So, your organization, if it's a 12-step organization, probably wants to think about, is that what I do best? Are there other people who can provide harm reduction services better? How do I work with and allow ease of kind of transition between those organizations? And then thinking about your own policies, what does it mean if someone has a relapse? How is that handled? And I know organizations sometimes think about harm reduction in that regard. So I hope that helps, because I'm talking about an organization itself and then an organization in relation to what I would call a continuum of care. And we've kind of laid this out in a paper that we did on harm reduction and housing and homelessness done a while ago.
Great, thanks for that response, Bernie. Our next question comes from Kathleen C. What would be your recommendations for youth serving organizations that are abstinence-based due to a vulnerable client population?
Really good question about youth. And this, I think, comes up a lot. And I think one of the first things you have to ask is, are the youth that you serve already using substances? If they are already using substances, then it is really important to think about harm reduction, a harm reduction set of interventions and draw from some of this work around harm reduction implementation, because if they are using substances and they're hiding their use because it's an abstinence-based organization, that will escalate harms. And the examples that we see a lot are things like people using in the bathroom, using in their room, overdosing without someone being aware, or naloxone not being available. If you're an organization where the youth there are committed to, they may have had past history of substance use, but their commitment now or their choices now are different, then that will look completely different. So I apologize if I'm not sort of answering these questions really clearly, but it does have to do with reflecting on your organization and who you serve and who else is able to serve individuals who are using substances in the community and who can do the work well. And there are lots and lots of people who can do the harm reduction work well, and that can collaborate in the work.
Great, thanks again. Our next question comes from Shannon Kay, and it's about rural areas. So how do you see differences in rural communities, and are there suggestions or resources that can help rural communities find success in implementing harm reduction where social dynamics are quite different from urban settings?
Yeah, I appreciate the question, because I think, some of this is premised on a fairly urban kind of model, and I'm going to add that into some of our limitations in terms of rural and urban. We do raise it in number 7 around geographic distribution. But the reality is, which you know better than I, that services, even the staffing and the resourcing to be able to have harm reduction services is quite difficult in rural areas. And it raises questions of kind of what can the community do together in collaboration. And one of the strategies that I'm aware of that has been pretty effective in some more rural kinds of communities has been the development of a drug strategy network where organizations come together. There was in the past funding for drug strategy coordinators, which was very effective kind of strategy. There is, and I don't know what province you're in, but British Columbia is one province, and there may be others. Please, 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 if you're in other provinces and you're aware of funding that can support things like community networks or community dialogues. We have a pot of funding in British Columbia that's been specifically for community dialogues around overdose, and that's been a really powerful kind of way for smaller, more rural communities to be able to raise issues about stigma and how stigma affects people in the community. And I think I've been to quite a few of them. And the focus on caring and compassion for everyone in the community that lives there together, and knowing that people are sometimes knowing that stigma is even greater in some of those situations. So those are some initial thoughts on rural and urban. I think from a health organization perspective, like a health funder organization perspective, our framework is really encouraging that they look at what's the geographic distribution and communities identifying what they need in their community, and recognizing. I've worked with a lot of smaller, more rural and remote communities where they've identified their need has been around things, more so around things like managed alcohol sometimes over supervised consumption sites.
Great. So I think we have time for one last question. There are so many incredible questions and comments, and don't worry, Bernie will get a chance to look at all of them. But let's round it out with a question from Deirdre H. And Deirdre writes, so often there is a large discrepancy between what the organization adopts as a framework and the reality of what support workers learn, believe, or practice. So Bernie, how do we use this framework and build a culture of harm reduction in frontline workers that are doing the actual work?
That is a brilliant question, and that's the million-dollar question, is we can have philosophies, but whether they get taken up into practice, and I loved how you phrased it, what workers know and believe. And it's what they know and believe about the policies, but it also points to what does the culture tell them, what are the norms in the culture. And so I think particularly where I would emphasize is, promoting education within the organization, ensuring that the policies are in place, that everyone knows about those policies. And, it can be a very kind of thoughtful process where people have opportunities to engage in their own reflections around substance use. What experiences have they had? What values do they hold? As a way of kind of reflecting and rethinking, how is that different, and how are we all affected by current drug policies? And so the two kind of fundamental pieces are, the education and the knowledge and awareness of the policies, and how does that help to create a different set of norms? Even that simple thing of paying attention to language and just saying, hey, I don't know if people would do this in a staff meeting, but in a staff meeting, like, gosh, I saw this poster about people first language. I've been really thinking about that. Is that something that, I really would like us to think about that. I'd really like to make it okay to do that. And I know that's it sounds like a super small thing, but just shifting kind of that language can really shift kind of the whole feel, the whole demeanor of kind of the organization, because there's an awareness then of that language comes from these broader sets of drug policies that do focus on prohibition and that do create harm. And I think the framework is very well aligned in the checklist to give some support for the need for both the education and the policies so that we can go from philosophy to practice.
That was great. Thanks, Bernie. So just taking a look at the time now, I don't think we have time for another question, but what we're going to do is pass all of these questions and comments along to Bernie, and then we're going to turn it into a blog post so that the responses that Bernie gives are accessible kind of to the whole group. So thank you so much to the audience for all of your questions and your insights. And of course, thank you to you, Bernie, for joining us here today. This is obviously an incredibly important topic right now. And I know that we all here appreciate you taking the time to speak with us and share your expertise. So thanks again, Bernie, and have a great day, everybody. Take care.
Great.